think we'll just wait a couple more minutes. Maybe we'll get started. So, Sidoni, do you want to explain the questions, or do you?
Yeah, so slight change to how we normally do our sessions. So this time with the questions, we just have a Q&A section since it's a webinar. So you can ask a question, or you can use the upvote option when you go into that. And it will allow you to vote up questions that you want to see answered if it's the same as what you would have asked. And yeah, most of the instructions are right there about raising your hand, and you can always email me if you have any questions during the session. The chat only works to send messages to the panelists. All right, and then second of all, just the territorial acknowledgement. We are hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueams, Squamish, Tsleil Waututh Nation, and the Métis Chartered Community of the Lower Mainland region. Okay, and I will hand this off to Claire to start our session.
Oh, all right. Well, welcome everyone. My name is Claire Harris. I'm a nephrologist at VGH in Vancouver. Hopefully some of you are joining us from across the province today. Feel free to use the question and answer, and then there'll be time at the end. I'll put my email address at the end, so feel free to email me if you have any questions related to this or anything else. I'm happy to answer, and feel free to give feedback about what you want to see in future sessions. We're always looking for ideas of what people want to see from primary care. It's not working. Hold on, technical difficulties. Okay, so I have no disclosures to declare any relationships or commercial interests relevant to this talk or others. No conflicts of interest. I will discuss the off-label medication, use of one medication, and I'll mention that. My main disclosure is that the topic that we're going to be talking about today is the medical perspective of renal cysts and kidney stones, which falls a lot under the purview of urology. So this talk is really just from the medical perspective, although I will allude to maybe when to refer to urology as well, in which case urology might be more helpful than nephrology and vice versa. So again, to mitigate bias. So we're going to talk about the approach to renal cysts that are found on imaging, a very common finding. We're going to discuss the management of renal cysts and need for specialist referral. We're going to briefly review the management of polycystic kidney disease, as a lot has changed in the last few years. That could be a talk in and of itself, but we'll just talk about some things that your patients who are on the new medication might be asking you about. We'll talk about the different types of kidney stones in the expected course, and to review the lifestyle and medical options for recurrent kidney stone prevention. So first we're going to talk about cysts. We have lovely polycystic kidneys on the right hand side of the screen after bilateral nephrectomy, sometimes weighing 20, 30 pounds. In the middle we have a simple cyst or complex cyst, and on the left a simple cyst. So renal cysts are a very common finding that you'll see in primary care. They're typically classified from a radiologic perspective by their distribution, size, and number. So the typical classification includes simple cysts, which are as simple as they sound, complex cysts, which we refer to by the Bosniak classification, polycystic kidney disease, which is a genetic disorder, acquired renal cysts, which occur in advanced kidney failure, medullary sponge kidney disease. And then there are a number of unusual conditions that are associated with renal cysts that are not very common, but that you may see, some of which present in pediatrics, like medullary cystic kidney disease, some of which may present with other manifestations like von Hippel-Lindau, or tuberous sclerosis. So we won't talk too much about those. And I always have trouble pronouncing the last one, even as a nephrologist. I blame it on the fact that it's a pediatric condition that we don't really see in adults. So simple cysts are pretty common, especially as people get older. The highest rate occurs in older males. So if we looked at a group of patients that are young, below 30, very few would have any cysts on ultrasound in the absence of a cystic kidney disease like polycystic kidney disease. But as you get above 70, which is many of the patients that we see in our practice, they're very common in 30% of people, and bilateral in about 10% of people. So they're very commonly found on routine imaging that's done for other reasons, and sometimes can be a concern for patients wondering what this means and whether it means that they have an underlying genetic disorder, whether this has an impact on their kidney function, and what needs to be done about it. Sometimes simple cysts can be multiple and bilateral, as I mentioned, but if you see bilateral cysts in younger people, then you should be thinking about polycystic kidney disease or other genetic conditions. The presentation is usually that of an asymptomatic person who has an ultrasound for one reason or the other. They very rarely rupture or cause pain or hematuria or external compression. And they don't cause renal dysfunction in and of themselves. So unless there's obstruction because of a massive cyst, which again, very uncommon, they do not compromise renal function. Now, when people have done association studies of looking at people with cysts versus people without cysts, there was in some studies an association with some mild degree of renal impairment and other conditions like hypertension. But this is really not borne out fully in the literature, and obviously it's difficult to know why people are having imaging done in the first place. There may be some confounding factors. In general, we think the significance of having simple renal cysts, so a single basically cell fluid-filled sac without any complex features, is of no clinical significance. And when those lesions, which I'll show you in a second when we talk about complex cysts, are followed up, the rate of malignancy is essentially 0%. So because of that, there's no follow-up imaging that's necessary if the radiologist tells you that this is a simple cyst, in clear as that. So if there's no complex features, they say it's a simple cyst or a Bosniak 1, then it actually does not require any follow-up imaging. Now, sometimes the images are not clear. There's a question of some irregularity. In that case, when they're not able to determine whether it's truly a simple cyst, there may be a need for further imaging, such as a repeat ultrasound to get better images, or a CT if the lesion is equivocal. But in general, you can reassure all your patients, especially that are older, that if you find simple cysts, it's usually of no clinical consequence. In terms of complex cysts, this is classified by the Bosniak classification, from 1, which are the simple cysts, all the way to 4, which have basically a 100% chance of being a malignant lesion. Traditionally, this classification was done based on contrast enhanced CT. So if you were to ever look at how this classification works, it depends on things like the Hounsfield units. But in actuality, these days, ultrasound, MRI, other modalities, you'll see radiologists sometimes use this classification saying that a lesion is, say, class 2F, even when it's an ultrasound. So things have changed a lot over time. So when we get from 1 to 4, it gets more and more concerning. And basically you can see on the right-hand side there that class 2 again are felt to have basically just a thin septation or microcalcification. 0% are malignant at follow-up. And then they made more recently this class 2F, of which has a very low rate of malignancy, but a rate such that it requires ongoing follow-up. And so those patients that are class 2F or above should be referred to urology given the risk of malignancy and need for expert follow-up as MRI and other imaging may be required. And as you get towards class 3, many times these patients will be offered surgery even without biopsies or confirmation of a pathologic diagnosis, just because the risk is high. Now, for some older patients, they may choose to monitor small renal masses, but that would be in the discretion of urology. So I would suggest that all patients that have 2F or above be referred to urology. These patients don't need to be seen by nephrology, although often we are seeing patients for CKD around the time of getting renal imaging as part of their CKD workup. We don't need to see them specifically for this reason. They should be seen by urology. Now, sometimes in patients with severe renal impairment that are found to have a lesion, we are consulted for other reasons, such as they may need a nephrectomy. They're wondering about partial nephrectomy versus radical nephrectomy and how their kidney function will fare after the surgery. So sometimes we'll be involved from that point of view. And then, as I mentioned, MRI can often be helpful for indeterminate lesions. So you'll see urologists order them quite a bit these days. Sometimes when we see patients that have questionable lesions on ultrasound, we also do MRIs if we want to avoid contrast in those with advanced CKD. So this is the classification if you ever wanted to know it, but you can rely on your radiologist to tell you which lesions there are. So the polycystic kidney disease is something that needs to come to see a nephrologist about. As you all know, it's a genetic disorder, which is relatively common, an incidence of 1 in 400, which manifests as multiple bilateral renal cysts, as well as extrarenal manifestations, and a significant risk of end-stage renal disease. So you can see on the right-hand side, this is a CT imaging of someone with large bilateral kidney size filled with large cysts, as well as cysts within the liver itself, enlarging the liver. So this is somebody who has advanced findings of polycystic kidney disease that would look kind of like that first picture that I showed you. It's usually autosomal dominant in terms of the genetics, but it can be autosomal recessive. And we do not uncommonly see patients who have no clear family history of this, either because it wasn't picked up or because they had a de novo mutation. So the absence of a family history does not rule out this condition. And so the presentation is kidney cysts. Liver cysts are common in about 50%, and you can get cysts in other places such as the pancreas. In terms of the complications you might see in your patients that have polycystic kidney disease or how they present to you, they may present with flank pain or gross hematuria that could present very similar to renal colic, but is due to actually rupture of a cyst itself. And that can be quite painful and is usually treated with supportive management. Infection can also occur either from those cysts being infected or otherwise in the urinary tract system. They can have hypertension quite commonly. They can have kidney stones more commonly. And then the mass effect of these massive kidneys and liver that you can see on the right-hand side can lead to symptoms like early satiety and tissue weight loss. In terms of the extrarenal manifestations, there's quite a few, although the incidence of them is quite low. The one that worries patients the most is the risk of intracranial aneurysm. And we do screen patients who have a family history of intracranial aneurysm or bleeding, or those in high-risk professions like airplane pilots. Also, we sometimes screen patients that are just really worried about it. Unfortunately, having a 1 negative screen does not, in a younger person, does not mean that they couldn't get an aneurysm later in life. So it's not a one or done. They also more commonly get hernias and cardiac valvular disease, and there may be a higher risk of renal cell carcinoma. But obviously what patients are most worried about is renal failure. In terms of when we were talking about the simple cysts or ultrasound in younger people, this is a table that you could refer to that's on the BC Renal Agency website and various websites that helps us determine, especially in those who don't have a clear family history of polycystic kidney disease, what kind of ultrasound findings would be helpful to rule in or to rule out polycystic kidney disease. So you can see that the positive predictive values for ultrasound diagnosis is quite good at all ages. So in other words, if you have more than 3 cysts when you're young or more than 2 in each kidney when you're in your middle age, you can have a very high likelihood, if these are typical in terms of their anatomy, of confirming a diagnosis of polycystic kidney disease. However, not having cysts, especially when you're young, does not rule out that you have polycystic kidney disease, but perhaps you're too young to have developed the cysts. So you can see that it's not until you're getting into your 30s and 40s that we could confidently say that you don't have polycystic kidney disease if there are no cysts. Still have some sense as people get into their 20s, and that's often why we don't start even doing screening for family members until they're into their 20s. In terms of the kidney failure that we see, overall polycystic kidney disease patients make up about 10% or close to 10% of prevalent HD patients in Canada. The kidney failure can be fast in terms of the progression once the kidney function starts to drop. Typically, the presentation is that patients who have polycystic kidney disease will see enlargement of their kidneys over time. The cysts get bigger and bigger. They may have symptoms, but their kidney function is actually quite good for quite a long time until those cysts get so big that they actually are compromising the ability of the renal parenchyma to be functional. But once that happens, it's kind of like the straw that broke the camel's back, and the kidney function can go down very quickly after that. And one of the best predictors that we're learning more and more about is, as per the mechanism, the bigger the kidney size, the faster the cysts are enlarging, the worse the renal prognosis is in terms of how quickly the kidney function will go down. So you can see on the right-hand side that there are different colors, and this is the Mayo classification that we use for polycystic kidney disease. And basically what we do is we measure the patient's kidney volume, either by ultrasound or CT, and then we can plot that kidney volume adjusted for their height by their age. And that gives us a really good sense of how quickly they'll progress. So if you were to map a patient who's 30, who has very large kidneys already, then they fall into the highest risk group, which is the 1E risk group. And you can see that those are the patients that typically drop their kidney function or their GFR quite quickly at 5 mils per minute per year. Whereas you could reassure somebody who's, say, 55 and doesn't have very large kidneys that they're at likely to progress very slowly. And for example, they may never require dialysis. Before we use this Mayo classification, we relied a lot on the family history of when they presented with renal failure, other members in their family, and things like genetics, but we don't routinely do genetic testing unless the diagnosis is unclear or there's some reason to do it for, say, pregnancy planning. The other main risk factors for progression of polycystic kidney disease is male sex and uncontrolled high blood pressure, as well as some lab findings. One thing that is really important to know from this point of view is that if you do have a patient who has some cysts in their kidneys, but the kidney size is reported as normal and their GFR is low, then you need to consider alternate causes for CKD. So when we see patients who, for example, they undergo a renal ultrasound, their kidney function is low, they have a couple cysts in their kidneys, but their kidneys are, say, 9 centimeters, we know because of the mechanism of how cysts affect kidney function that that's not the reason their kidney function is low, and we need to consider other things. In terms of the treatment, because we rely on, a relationship with primary care as well to help with this and reinforce things, the treatment model for polycystic kidney disease is moving more and more towards having patients be followed in multidisciplinary clinics, like kidney clinics, where they can be seen by dietitians and pharmacists as well as nephrologists because we're learning more that the lifestyle in addition to the medications is really important for their success. And we're wanting to see these patients earlier on, as the therapies that are coming out likely have a larger benefit if they're started early. So the main treatment in terms of diet and lifestyle is some amount of protein restriction, a low salt diet, and a high fluid intake. Now, the high fluid intake is somewhat controversial, but basically we think that if patients drink a lot of water and maintain dilute urine, then the cyst growth may be inhibited as ADH is inhibited, which can drive cyst growth. For similar reasons of avoiding volume depletion, we suggest avoiding excess caffeine. In terms of blood pressure control, ACE inhibitors and ARBs are first line for people with hypertension and polycystic kidney disease. But one really important study that was called HALT-PKD showed that in younger patients with preserved kidney function, so age under 50 and GFR over 60, so long as they didn't have any other significant cardiovascular morbidities, we should actually target quite a tight blood pressure. So less than 110 on 75 if tolerated. Obviously you have to individualize it. And this was based on home blood pressure monitoring. So you may see that we're asking to tighten up blood pressure control quite low in these patients because it had shown to prevent progression of polycystic kidney disease. But for those that are over age 50, we don't have the same evidence, as they weren't included in this trial. So we usually say around 130 over 80 or less, although we don't really have evidence to say that this is the right target. And blood pressure targets, as you all know, is always a moving target. The main thing that has come out in the last few years, initially with some reticence, but more and more strong evidence is coming out, is the benefits of Tolvaptan, which is a V2 receptor antagonist, which is an oral tablet taken twice a day, as the only disease-specific therapy that's available to slow disease progression and slow cyst growth in those who are at high risk. So when I showed you that Mayo classification, those people whose cysts got big quickly, whose kidney function went down quickly, who are under 65 and still have a GFR above 25 may benefit from it. Now, we had a few barriers in terms of using this medication before. There was a significant concern, and there is a black box warning in terms of the risk of liver enzyme abnormalities with this medication, which is why it's only given with very close monitoring, and actually patients can't get access to their medication until they've done their blood tests. The other barrier is the side effect profile is often really difficult for patients, especially if they're young and working, as people will pee liters and liters and liters a day. A lot of polyuria, polydipsia, and nocturia. So you really have to have a motivated patient who really wants to do anything they can to delay the onset of dialysis or transplant. The other barrier used to be cost, but now those who qualify for it can have this covered in BC as of, I think, probably 6 or 12 months ago now, it's been covered. So this is part of the reason with this benefit of this medication, and there's many others coming down the pipeline, why we want to see patients early, as we want to try to slow down the growth as much as possible. I can't actually see if there's questions, so I'm not sure if there's any questions, but I'll move on. Another condition that you might see incidentally found on ultrasound or as part of workup for kidney stones is medullary sponge kidney, which is a congenital disorder which isn't exactly inherited in a typical genetic way. That happens from malformation, sort of a developmental abnormality of the terminal collecting ducts in the renal pyramids. And these leads to basically small cysts, sort of diffusely, you can see in this picture here, but they do not involve the cortex, so they're not cortical cysts. It's relatively rare, but relatively common when you're seeing a group of patients with kidney stones. Some patients are asymptomatic and it's just a imaging finding, whereas others can be bothered by frequent urinary tract infections, gross hematuria, even in the absence of kidney stones, recurrent kidney stones, and chronic pain that can occur and be quite debilitating even when there is no stone on imaging. They can also have changes in their urine concentration abilities. Fortunately, the risk of CKD is low overall and the treatment is largely supportive, but this can be a condition that's very bothersome for patients, and so we see them not uncommonly. The other rare cystic disorders, just FYI, are not going to be commonly seen. Medullary cystic kidney disease in sort of pediatrics, von Hippel-Lindau may be found as part of a workup for RCC. And then tuberous sclerosis is something that we kind of come across when it comes to patients who have angiomyolipomas, which if they're large can be associated with potentially life-threatening bleeding and requires urology involvement, which may require surgery or embolization or medication therapy. So sometimes we get involved along with urology. So suspect this if you see bilateral AMLs, if there's a family history, or you see neurologic or dermatologic manifestations, which can be severe. So in terms of when to refer for cysts, any patient with suspected PKD should be referred to nephrology, even if renal function is normal. If you have questions about the imaging findings in that table that I showed you and you're not sure, always just send us a note and ask us if we think it's high enough likelihood that they should be referred. But definitely when in doubt, especially with younger people, definitely if there's a family history, we would have a low threshold to help sort that out for you. Patients who have complex renal cysts, as I mentioned, 2F and above, should be referred to urology and not nephrology for management. And simple cysts do not require referral or follow-up imaging if radiology is confident. As I mentioned before, the management of AMLs can be both disciplines, as well as medullary sponge kidney. And the pediatric conditions are kind of on their own. So we'll move on to kidney stones. So this is my attempt at a joke. So kidney stones, as you know, are very common. One kidney stone episode will occur in about 10% of adults during their lifetime. There is a slight male predominance, and it does vary geographically as some of metabolic conditions make kidney stones more common, like in the Western world. Approximately 50% will have one or more recurrence after having a kidney stone episode at 10 years. And then, as you know, probably patients in your practice, there are also many patients who have kidney stones several times a year. So people tend to fall into different groups, one that just has a one-off kidney stone or maybe one other 10 years later, another group that has a kidney stone every year or two, and then another group still that seems to get kidney stones 2 or 3 times a year and is in and out of emerge and in and out of the urology office all the time. And so that can be associated with significant morbidity, but fortunately is a rare cause of end-stage kidney failure. In terms of the pathophysiology, I'm sure you're all familiar with the fact that this predominantly occurs due to supersaturation. So you have an increased amount of crystal-forming substances such as calcium, uric acid, or oxalate relative to the urine volume. Stasis of the urine can also, either from low urinary flow or bladder outlet obstruction, can help this crystal growth. And then a decreased amount of inhibitors that are normally in the urine to prevent supersaturation is often a key factor, like low urine citrate. Other structural abnormalities and urinary infections can also play a role. In terms of the main types of kidney stones, calcium stones are the majority of kidney stones. They are most commonly calcium oxalate, but can also be a mixture of calcium oxalate and calcium phosphate, or less commonly calcium phosphate alone. Uric acid stones are the second most common, and struvite stones or staghorn calculi are infection related and the third most common. Drug-related stones are not that commonly seen. Sometimes they're drug-related in the sense that they are, the drug itself is creating an environment where stones are more likely. So changes in the urine pH, vitamin C, carbonic anhydrase inhibitors, topiramate, or sometimes the stone is actually crystallization of the drug itself when it's supersaturated. So the classic example would be the HIV drug indinavir. but other antimicrobials can also do this, as well as triamterene and methotrexate. There are several other rare stone disorders like cystinuria and primary hyperoxaluria, which are a lot less common. So in terms of when you see a patient that has recently been found to have a kidney stone, either incidentally or with symptoms, if you want to kind of know what type of kidney stone your patient has, know that the most common cause is calcium. But in terms of history, they may have something on history in terms of medications that make them more likely to get one type of kidney stone or another, family history, prior GI surgery or history of bowel disease that would predispose them to calcium oxalate stones, frequent urinary tract infections or symptoms of that could predispose them to struvite stones. And then you may do on initial lab testing, find some sort of abnormality like a new diagnosis of primary hyperparathyroidism, which is associated with calcium phosphate stones. And we'll go through the stones in more detail, including the 24-hour urine. The pH can also give you a clue. So uric acid stones like to form an acidic urine, whereas calcium phosphate crystals like to form an alkaline urine. And urine is usually alkaline in the struvite stones because of the pathophysiology. One thing to note is that if you see a urinalysis that shows calcium oxalate crystals, this is actually quite common in concentrated urine and does not necessarily indicate the presence of stones. However, if you saw somebody who had kidney stones and then you did a subsequent urinalysis that showed calcium oxalate crystals, that probably gives you a clue that that's the type of stone that they have, but not definite. Imaging findings, we all know about radiolucent versus opaque stones. Main radiolucent stones are uric acid stones. And then if you can get the patient to collect their stone itself and send it for stone analysis, that's the best way to know what that's done, or that could be done by the urologist at the time of a stone procedure. So in terms of calcium stones, I mentioned calcium oxalate is the most common. And so it's a presumed diagnosis unless there's atypical features. There are certain conditions that, as I mentioned, in terms of bowel resection or inflammatory bowel disease that predisposes to this due to hyperoxaluria, and sometimes runs in the family, but you don't need to have hypercalciuria or hyperoxaluria in order to get these stones. So it's very common that we see patients who have calcium oxalate stones who do not have these abnormalities on their metabolic or 24-hour urine workup. But the relative amounts and what's considered normal, they may fall on the sort of upper limit or lower limit of normal depending on the condition. Calcium phosphate, as I mentioned, form an alkaline urine, and they can be associated with other conditions such as distal renal tubular acidosis. So you'd see a patient who has on serum blood work a low serum bicarbonate. Can be associated with primary hyperparathyroidism, and the clues would be high calcium or high PTH. Chronic urinary tract infections also can predispose, as well as hypercalciuria and hyperphosphaturia. And again, it's most common to see a mixture of these types of stones, but sometimes you'll see isolated calcium phosphate stones, such as with RTAs. Uric acid stones aren't always associated with hyperuricasuria, but it can be more common. Those who have gout, metabolic syndrome, chronic diarrhea, obesity are more likely to get uric acid stones. And as mentioned, they're not seen on X-ray. Struvite stones are these ugly looking staghorn stones that can grow to be massive and can grow very quickly. They form in the infected upper urinary tract, in particular people with structural abnormalities that predispose them to recurrent urinary tract infections. So they often are very, very large, require multiple procedures, and often chronic suppressive antibiotics, and can be quite comorbid. Cystine stones are very rare. It occurs due to reduced renal absorption of cystine, often presents in childhood and can be associated with recurrent stones as well as staghorn calculi. This can be a very difficult condition to treat, and we have limitations in terms of what access and what medications we have. So in terms of when to refer patients with kidney stones, all obstructive stones should be referred to urology urgently. Many of those patients will be seen in the emergency department. Some of them will have a trial of trying to pass these stones on themselves, depending on the size of the stone, but should have follow-up with urology nonetheless. Any stones that are symptomatic should also be referred. Any stones at all in a patient with solitary kidney, or sometimes a kidney, they may not have a true solitary kidney, but one kidney is atrophic and their quote unquote good kidney is the one that has the stone. That's much more likely to lead to renal compromise and should be referred to urology for urgent management. It's a little bit more tricky in terms of what to do with small incidental stones that are seen on ultrasound. One thing that's important to consider is that, because we see this all the time because we order ultrasounds on basically every patient that we see if it hasn't already been done for CKD workup. If they're very small, sometimes ultrasound can overcall the size of kidney stones, or actually sometimes when further imaging is done, there actually is no kidney stone there. So if you have a small stone, in particular less than 4 millimeters on ultrasound, it would be good to get a CT KUB or KUB X-ray to better elucidate the stone size at the time or prior to referral of urology. I think it's kind of up to you in terms of your comfort level, whether you want to refer all patients that have stones regardless, or whether this is something you feel comfortable following serially yourself in a patient who has a very small stone that's asymptomatic and found incidentally, whether you choose to do repeat imaging, basic workup and follow up yourself, or whether to refer them all onwards. But all kidney stones, even in first-time kidney stone formers, need a basic workup and dietary advice. So this would just include a urinalysis plus or minus culture, depending on their symptoms, serum electrolytes. So you would be looking for clues like, do they have a low bicarbonate? Do they have that could clue to something? Do they have a high calcium? Do they have an abnormal creatinine that would make you concerned? And so those kind of basic tests are what you would do for someone with a first-time stone, sort of a basic workup. But some patients require a much more in-depth evaluation. So any patient with recurrent kidney stones should be referred to urology plus or minus nephrology to get a more detailed metabolic workup. So this would entail an additional blood work as well as a 24-hour urine for metabolic workup. The reason that these patients need to be referred is not just for the metabolic workup, but the fact that they probably need more tailored dietary advice and may require medications in addition to lifestyle changes to help reduce the recurrent risk of stones. You can see on the right-hand side of the slide, this comes from the CUA guidelines about which patient should be have a detailed in-depth evaluation for stones. So that also includes people that are children, regardless of whether they've had more than one stone episode or not. And just to note that many places have stone clinics that are multidisciplinary with dietitian support as well as nephrology to help with recurrent stone formers. The ones that I know about, we have one at VGH. I believe there's one in Surrey. I think maybe on the island as well, although I'm not sure. But nephrologists around the province are happy to see recurrent stone formers to help urology with the metabolic or medical side of things. And multidisciplinary stone clinics have been shown to reduce stone recurrence rates. So there's a well-known phenomenon of the stone clinic effect, whereby patients seem to take some of the dietary advice in particular more seriously with all the encouragement. And I think the dietitian is the most important member of that team. So these are the tests that we would do if we saw somebody. If you feel that you want to do these tests ahead of time or you have a high suspicion that you might get an abnormal result, these are the ones that you would order. And the 24-hour urine collection can be a pain, but it can yield some useful information in terms of how to tailor dietary or medication advice. So in terms of the proven treatments for kidney stone prevention, the number one treatment, which cannot be emphasized enough, is increasing fluid intake. So this has been shown to reduce stone recurrence bias, 60 to 80%, like very high effectiveness. So we recommend fluid intake of 2.5 to 3 liters per day. And basically, we're trying to target a urine output of 2 to 2.5 liters per day or more. And this, as I mentioned, is most important. Water is best, but for some patients that don't like water, we'll figure out a mixture of things, but we want to avoid, caffeinated beverages or other things that might not be as helpful. But if we can get people on water, that's best. And obviously it takes some time to getting used to. The second most effective therapy is supplementing citrate. So if we raise urine citrate, which is an inhibitor of stone formation, this helps, as well as the fact that this is a base or alkali, raising the urine pH to, again, make the conditions for stone formation not as good. So this can be done from a dietary perspective using lemon concentrate or squeezing lemon into water, or can be done with a supplement, most commonly potassium citrate, which is usually split into BID dosing. You do have to make sure that they don't develop hyperkalemia when you put them on it, and there is sodium citrate, but it's less effective. So usually we will sort of slowly uptitrate the potassium citrate and check the electrolytes after starting it. Thiazide diuretics are also found to be effective even in those who do not have hypercalciuria with recurrent stones. So it does reduce urinary calcium and reduce stones that way, but there seems to be a beneficial effect even in those who don't find hypercalciuria on their 24-hour urine. So that's why I mentioned that this is technically an off-label use of thiazides if a patient doesn't have hypertension, but is quite effective for stone prevention. So sometimes all this may mean is that you have a patient who's, say, on a calcium channel blocker, and then you choose to switch them to a thiazide for their high blood pressure because it'll have the dual effect of reducing stone risk if they're a kidney stone former. Again, it's important anytime you're starting a thiazide to repeat electrolytes, in particular, looking for hyponatremia or hypokalemia a couple weeks later, especially in older people. And then, of course, monitoring for hypotension in those that are not hypertensive. And you may want to use a longer acting thiazide like chlorthalidone. Allopurinol helps prevent stones as well in terms of reducing uric acid. It hasn't really borne out to be effective for people that don't have uric acid stones. That was studied, but it wasn't particularly helpful. In terms of other dietary advice, one of the biggest misconceptions is that patients need to restrict their dietary calcium if they have calcium-based stone. But it's very important not to restrict dietary calcium. So you actually need to make sure that the patient's dietary calcium is sufficient, so up to 1,200 milligrams per day. But we usually avoid calcium supplementation in terms of pills, with some exceptions. Sometimes for patients with recurrent calcium oxalate stones with hyperoxaluria, we give them calcium at the same time as their food, kind of as a binder, but that's not usually the first line thing that we do. But that's often a big misconception, so they actually have to make sure they have enough calcium in their diet. Restricting sodium is also helpful as it reduces hypercalciuria, so low sodium diet. Oxalate restriction has not been found to be that helpful. So for those who have high oxalate in their urine or calcium oxalate stones, they'll often restrict, those dark green leafy vegetables and chocolate and nuts, and may make their quality of life a lot worse, but may not actually help that much in terms of what the evidence shows us. That being said, we usually do educate people to reduce oxalate in their diet, but a very, very strict restriction is not likely to yield that much more benefit. In which case we might be doing things like having the mealtime calcium. Not too much protein has also been found to be not helpful, especially for those with uric acid stones. They should restrict high purine foods. And then you want to avoid excessive vitamin C intake. In general, we educate people to have a diet that's high in fruits and vegetables. Some of this may help with their citrate intake, but it may just be a marker of somebody who's generally healthier and conscientious. this is one of the handouts that we always give to patients at the VGH Stone Clinic, which is pretty basic, that you could use in your offices. There are many good handouts that are available, but this one's quite basic. In terms of other treatments that we might use, I mentioned the calcium with meals sometimes. Sodium bicarbonate is sometimes used for urine alkalization other than potassium citrate. And then there's some disease-specific therapy like penicillamine for cystinuria or antibiotic used for struvate stones. So I have some slides that come from the CUA guidelines that talk about what you would do for different kinds of stones in terms of medications and dietary advice that I'll put at the end that you can look at after. But basically, I just wanted to have a really simple presentation, but give enough time for people to ask questions if they had questions in particular about, you know, when's the best time to refer to nephrology versus urology versus follow things on their own. So I'll kind of open it up to questions. I can see there's some questions here. Okay, so the first question that I see is, for incidental findings of simple cyst on ultrasound, does it matter how large the cyst is if follow-up ultrasound is needed, i.e. 6 centimeters or greater? So the answer would be no, unless there was a feeling that there was symptoms associated with it. So sometimes these large simple cysts can cause compression or symptoms. So if you were worried about symptoms as a consequence, you may want to follow it, because in the rare occasion, those cysts sometimes are deroofed either surgically or percutaneously for symptom benefit. So that's kind of thing. If you were more worried about symptoms, you may want to consider asking urology about that or rechecking and imaging, but not because of cancer risk. Even if the cyst is very large, as long as it's simple and has none of those high risk features, you wouldn't be worried about risk for cancer. So the second question is about vitamin C supplementation. So yeah, so the definition of high is a little bit controversial. Usually people will say less than 1,000 or 2,000 per day in terms of the max amount of vitamin C you'd want to have for recurrent stone formers. But I have to say the evidence is not that strong. So it is the advice that we give. Mostly people that have had problems with recurrent stones are motivated to do whatever they can. And I'm not sure, you know, a particular person, how strongly they really need the vitamin C supplement. So usually they'll be in agreement to at least reduce what they're taking. The third question is about how often we do 24-hour urines on the patients we're following. So usually we'll do a 24-hour urine when we first see the patient as sort of like a baseline. Then we'll give them, say, a common finding would be that, say, a patient has a 24-hour urine. They have a very, very low urine citrate. So our dietitian will talk to them about, and maybe a low urine volume, and say maybe also a high salt intake. So they're going to work on reducing their salt intake. They're going to work on increasing their urine volume by having more water, and they're going to add lemon concentrate or lemon juice to their water. So we'll let them do that for practically speaking, like a month or several months, and then we'll do another 24-hour urine before we see them next, and then see if the changes had positive results or not. If they continue to get kidney stones and that urine citrate remains low, for example, that would be when we'd probably switch them to potassium citrate. And then we may consider repeating it, you know, 6 months down the road. So usually it's in the order of many months, just practically because of how we're following people. And it takes them some time to work on these kind of lifestyle modifications. So we don't really do them like in the order of weeks. It's usually months, but there's no kind of right answer for that. And it's a bit controversial whether you should do one 24-hour urine or two 24-hour urines. It really is just a snapshot of what's been going on in their lives around that time. Always take it with a grain of salt, but patients generally don't like doing too many of these tests because it's very cumbersome. So we usually try to keep it practical and also consider whether we're going to really be doing anything for this information with the information. So some patients will say, yeah, I don't I'm doing my best, or I don't want to take lemon concentrate, I don't want to take any medications, I don't want to make any changes, in which case doing the 24-hour urine again is not helpful. The next question was about dentists and lemon water. Yeah, I think there is a concern in terms of the acid effects on teeth. I can't comment on that much more than that in terms of what I know about dentistry. For patients that have a lot of concerns about that, I would recommend using the potassium citrate supplement instead of the lemon water. Practically speaking, some patients do have things like heartburn or concerns about taking lemon water, but most people do tolerate it very well, as we usually recommend diluting it quite well. So our dietitians will kind of work with them. But if there's someone who I'm not seeing is really practically taking it or has concerns, then potassium citrate is a pretty benign intervention, so long as you check their potassium. The next question is about B6. So not typically, so I'll show you the CUA guidelines about that. I can share back my slide. So the main, oh, hopefully you can see this. Oh, it's not working here. So the main time that we would do that is if we kind of felt like we had tried our best in those with hyperoxaluria, with using the, enough dietary calcium, the dietary modification in terms of oxalate, and then probably doing the calcium as a binder with their meals. But it definitely is on the algorithm, not as commonly done, but can be done if other things aren't working. Don't know, is there any other questions? I think practically speaking, you may be able to, in the community, also access dietitians that have familiarity with kidney stone prevention without having them come to the things like the stone clinic. I find the dietitians, because they'll follow patients over time and do dietary journals, make a really big difference in terms of making meaningful changes. Any other questions, or did I not answer any of them? Okay, well, feel free to email me, claire.harris@vch.ca. Hopefully, yeah, if you have other questions, you think somebody could benefit from seeing a nephrologist, it is something that across the province that we're all comfortable with seeing, so they don't have to be at a main center, and hopefully you learn something useful. Please fill in the feedback, especially want to just plug, especially sessions you would like to see from the group of nephrologists down the road. We really appreciate direction in terms of what you guys want to see. Okay, thank you so much.